team that's going to manage patients with mesothelioma, both in the fact that we can help with the diagnosis and the staging of the disease, as well as helping in guiding the best therapies. And it's always good, I think, to have a pulmonologist on board if you're discussing, for example, surgery or radiation therapy, because underlying lung function is going to have a great impact upon whether or not a patient's going to be a candidate for an intervention. A patient may be a perfect candidate for surgery, but may not be someone who could survive the surgery from a lung function perspective. So I think our general pulmonary skills do come in handy, even though we're very interested in the scientific side.
So, Tobias, I wonder if you could just the basics. After an extrapleural lumenectomy, how does a patient breathe? Could you sort of explain, how the other lung will take over, and sort of some of the changes of, what are patients to expect following that type of a surgery?
Yeah, the extrapleural lumenectomy is obviously a very invasive surgery, as you've heard in some of the previous presentations. During an extrapleural lumenectomy, the lung as well as the pleural surfaces are pretty much excised in an en bloc procedure, so they all come out as one piece, so to speak. And what that pretty much does is, not only does it mean a lot of trauma to the patient, so it's a big surgery that causes quite a bit of tissue injury and results then in has to require a lot of healing afterwards. You also pretty much lose 50% of your lung function in this context. And it's also important to know that as we all go through life, we acquire lung diseases that affect our lungs. And so if I say 50% of your lung function, you're basically left with the other half of your lung, and that may be affected by a different disease. For instance, some patients smoked during their use, and they may have COPD or emphysema, which may affect the other lung. So it may not be exactly 50% of the ideal lung function. So it really drops your lung function quite a bit and causes, in that context, your functional status to potentially deteriorate, and in some situations, patients to be left with a functional status that would be very difficult to maintain their quality of life and potentially require oxygen. And obviously that's one of the things that we try to avoid by selecting patients appropriately when we decide what surgical procedure they are subjected to, is that we actually really try to preserve quality of life as best as possible and preserve lung function as much as possible with these surgical procedures, and try to do this in a proactive fashion where we actually try to select the right candidates for the right surgical procedure up front. Because in contrast to extrapleural lumenectomy, pleurectomy and decortication, the competing surgical strategy is designed to preserve the lung, and therefore patients actually typically end up with more lung function at the end of the procedure. But I think it's important to recognize that it is a dramatic change. That being said, typically, if you have healthy lungs, one lung actually can provide pretty good function for a patient. As is actually an example for that is when we perform lung transplantations. In patients with end-stage lung disease, we actually frequently only transplant one lung, and patients can gain decent lung function after a single lung transplant.
Dr. Sturman, following an extrapleural pneumonectomy, if you develop a pleural effusion, how safe is it to insert a Pleurex catheter for draining those infusions at home?
Are you talking about on the side where the pneumonectomy was done?
No,
or the
I'm talking about the
side?
contralateral side when the disease
I think
returns.
it's very safe. I mean, you have to use ultrasound to guide those procedures. And I think as long as you're using ultrasound guidance and the person who's doing the procedure knows what they're doing, it should not be a problem.
Okay.
I mean, the biggest concern from my perspective is that when you have a pleural effusion on the side of your remaining lung, that it's a harbinger that the disease has now recurred in the site where you only have one lung remaining, and it's a bad prognostic sign, unfortunately. So I think we can do procedures, but from a prognostic perspective, I think we have to be honest with ourselves about what it means to have that pleural effusion on that side, if it turns out to be positive, for example, for tumor cells.
And now, how do you manage, what is the rate of infections once you've inserted a Pleurex catheter? I believe it's pretty low, am I correct?
It's 5% or less in general, and most of them can be managed by a course of oral antibiotics, leaving the catheter in place.
Okay, great. Radiation-induced pneumonitis, we hear about that a lot. Could you explain a little bit about what it is and then how is it managed?
Sure.
Okay.
Yeah, so radiation pneumonitis is pretty much an inflammatory response that's caused by the ionizing radiation exposure of the lung. We really manage this with anti-inflammatory therapy. So for the most part, that involves a course of prednisone that is administered to these patients. The dose and length of the therapy varies a little bit between centers. So a lot of this is what centers have established in their experience of being helpful. But and in addition to that, you try to provide supportive care to the patient. Obviously, we are trying to limit radiation pneumonitis also, again, when we plan therapies for these patients. And that highlights again, the point that Dan already made, that this is really a team approach. And that's how we look at these patients, that this is a multidisciplinary team that's looking after the patient, where really all these specialties, radiation oncology, surgery, medical oncology, and pulmonary medicine actually come together and take care of an individual from the beginning, where we plan the therapy, and in the context